Emotionally, this can be a tough conversation. Some people feel relieved when they hear they might be able to avoid that total knee replacement. Others feel frustrated that they're being told to wait or worried that choosing a partial might mean more surgery later. Both reactions are understandable. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle, and in the last episode, we talked about minimally invasive knee replacement and why labels don't reliably predict recovery or long-term outcomes. Today, we're continuing that conversation with a topic that's often mentioned in the same breath, but means something very different, and that's partial knee replacement. Many people hear this phrased as, "You don't need a full knee yet," or "You might be a candidate for a partial." And for some people, that's absolutely true. For others, it's confusing, frustrating, or even anxiety-provoking. So today, we're going to slow this down and talk through what partial knee replacement actually is, who it's for, and what the research shows about outcomes and some trade-offs. Partial knee replacement is defined by what is replaced, not how big the incision is. The knee has three compartments: the medial compartment on the inside of the knee, the lateral compartment on the outside, and the patellofemoral compartment where the kneecap meets the thigh bone. In a partial knee replacement, only one of these compartments is resurfaced or replaced. The rest of the joint structures are left intact. That's the defining feature, not the incision size, not whether the surgery is called minimally invasive. Partial knee replacement is a different operation because it replaces less of the joint. This is one reason partial knee replacement is often confused with minimally invasive surgery. Many partial knee replacements are done through smaller incisions, and early recovery can feel easier for some patients. But those features are secondary. The real distinction is anatomical and mechanical, not cosmetic. This idea of looking past labels is something I think a lot about in my work, including while writing my prehab book, The Knee Replacement Game Plan, your step-by-step plan to prepare for total knee replacement success. Whether a surgery is called partial, total, minimally invasive, or robotic, the label itself tells you far less than understanding what's actually being changed inside the joint and how that decision fits into a longer-term plan. One important implication of replacing less of the knee is that more of your natural anatomy is preserved. In a single compartment partial knee replacement, knee ligaments, often including the ACL or anterior cruciate ligament, remain intact. Biomechanical and gait studies show that preserving these structures helps the knee move in a way that's closer to how it moved before arthritis took over. This helps explain why many people report that a partial knee can feel more natural, especially in the early months after surgery. Who then is a good candidate for a partial knee replacement? Before we go further, there's one question that comes up often, and it's worth answering clearly. Is there ever a partial knee replacement that involves more than one compartment? And the answer is yes, but it's uncommon. In select cases, surgeons may consider what's called a bicompartmental knee replacement, which replaces two of the three compartments of the knee while leaving the third intact, most often the medial compartment and the patellofemoral compartment. Now, these procedures are used infrequently, and registry data from the UK and Australia show very low utilization, and outcomes have been less predictable than either single compartmental partial knee replacement or a total knee replacement. Because of higher technical demands and higher revision risk, bicompartmental replacement has not become a standard solution once arthritis extends beyond one compartment. And for most patients, involvement of more than one compartment is the point where surgeons begin to recommend total knee replacement rather than trying to preserve part of the joint. With that clarified, who is actually a good candidate for a partial knee replacement? Research and professional guidelines are clear that candidacy is relatively narrow, though it has evolved over time. A 2024 narrative review by Thus Steinman, Lustig, and Calise outlines how older, rigid rules, such as strict age cutoffs or automatically excluding anyone with kneecap arthritis, have softened as implant design, surgical technique, and understanding of failure mechanisms have improved. And that doesn't mean partial knee replacement is suddenly right for everyone. It means that in experienced hands, surgeons are often making more nuanced anatomy-based decisions than older checklists suggested. Arthritis still needs to be truly isolated to a single compartment, or at least functionally dominated by one compartment in a way that makes preservation reasonable. The knee must be stable enough and alignment needs to be correctable into a range that allows the remaining compartments to function normally. While newer literature discusses expanding indications, such as larger varus alignment, certain patterns of patellofemoral arthritis, or select ACL-deficient knees, these situations require careful selection and experience. And that's why you need to really discuss this with your surgeon. And this is why imaging and physical examination matter more than pain severity alone. Someone can have significant pain and still not be a good candidate if arthritis is present in more than one compartment. And someone with less pain may technically qualify, but still need to weigh whether partial replacement makes sense long term. And this brings us to the trade-offs. When partial knee replacement is done in the right patient by a surgeon who performs the procedure regularly, early outcomes can be very good. Most of this evidence comes from observational studies, matched cohort analyses, and registry data, rather than large randomized trials. On average, these studies show faster early walking, less early pain, and a knee that can feel more natural in the first months after surgery. These are group-level trends, and they're not guarantees for every individual. But the long-term data tell a more complicated story. Large national joint registries give us the clearest picture here. The UK National Joint Registry and the Australian Orthopaedic Association National Joint Replacement Registry both track hundreds of thousands of knee replacements over time. Across these registries, partial knee replacements consistently show higher revision rates than total knee replacements at the population level. To put numbers to that, 10-year revision rates for partial knee replacement are commonly reported in the range of about 10 to 15%, compared with roughly 5% or less for total knee replacement over the same time frame. Now, this does not mean partial knee replacement is a poor operation. It means the margin for error is smaller. And it's really important to acknowledge that there's a legitimate variation in expert practice, and reasonable, well-trained surgeons may weigh these risks differently based on their experience, the patient population, and the technical approach. A key interpretation point helps this data make sense. Revision rates matter, but they are not a perfect stand-in for how well a knee is functioning day to day. A well-known critique by Goodfellow and colleagues pointed out that surgeons tend to have a lower threshold to revise a partial knee than a total knee, in part because converting a partial to a total is often a straightforward next step when arthritis progresses elsewhere in the joint. That can exaggerate differences in registry statistics if every revision is treated as the same kind of failure, so to speak. The practical takeaway remains the same. Partial knees carry a higher likelihood of another surgery over time, but many people function very well for years before arthritis progression makes conversion the most sensible option. It's also helpful to understand why revisions happen. In many cases, the implant itself has not failed. Instead, arthritis progresses in the parts of the knee that were not replaced. This progression is a known risk and part of the trade-offs patients consider when choosing to preserve part of the joint. Technique and precision matter here because the implant surface is smaller. Restoring alignment and joint line accurately is especially important. And the 2024 review also highlights how newer tools such as computer-assisted planning and robotic assistance may reduce positioning outliers. These technologies don't change who's an appropriate candidate per se, but they may help experienced surgeons execute the plan even more consistently. Registry analyses from both the UK and Australia show that surgeon volume matters more for partial knee replacement than for total knee replacement. Surgeons who perform partial knee replacements frequently have much lower revision rates than those who perform them occasionally. This volume-outcome relationship is one of the most consistent findings in the literature. So when people ask whether partial knee replacement is better, the most accurate answer is it depends on the patient, the anatomy, and on the surgeon. Another important point is that a revision from partial to total knee replacement, it's not a failure in the dramatic sense people sometimes imagine, but it's another major surgery, and the likelihood of needing that second operation is all a part of the informed decision-making. Emotionally, this can be a tough conversation. Some people feel relieved when they hear they might be able to avoid that total knee replacement. Others feel frustrated that they're being told to wait or worried that choosing a partial might mean more surgery later. Both reactions are understandable. What I'd really like you to hear is that needing a total knee replacement is not a failure, and choosing a partial knee replacement is not a shortcut. They're different tools for different situations, and that's something that you need to have a good, honest discussion with your surgeon about. So when you talk to your surgeon about partial versus total knee replacement, here are a few questions that might help clarify the decision. They include, what compartment is my arthritis actually in? What makes me a good or poor candidate for a partial? How often do you perform partial knee replacements? And if arthritis progresses, what does the next step look like? These questions don't require you to understand surgical techniques in detail, though you might enjoy finding out more. But they do help you understand the plan. From a rehabilitation standpoint, it's also important to reset expectations a bit. Even when early recovery feels easier after a partial knee replacement, rehabilitation still matters. Strength, walking tolerance, balance, and confidence all need to be rebuilt. Underestimating rehab because the knee feels pretty good early on can unfortunately limit long-term success. But before we close, let's pull this all together. Partial knee replacement can be an excellent option for the right person. It replaces less of the joint, preserves more natural anatomy, and can offer very good early function and long-term satisfaction in carefully selected patients. At the same time, candidacy is narrower. Surgeon experience matters, and the risk of needing another surgery later is higher than with total knee replacement. None of that makes partial knee replacement wrong. It just makes a decision worth slowing down and thinking through carefully. Labels don't determine outcomes. Preparation, appropriate decision-making, and consistent rehab do. In the next episode, episode 34, we'll continue this series by looking at robotic-assisted total knee replacement, what the technology actually does, what the research shows, and what it doesn't change. Until next time, I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.